Yeah. Hi, my name is Justin Griffin. I'm a family nurse practitioner student at United States University, and I'm going to be doing a lung exam today, or assessment. Can you tell everyone your name?
Katrina Griffin.
And do you consent this to go on YouTube?
Yes.
And do you consent for me to touch you?
Yes.
Okay. Then, just like any other or most of the exams that we do, is we start off with inspection. So we're going to check for respiratory rate. We're going to check to see if she's using her auxiliary muscles, or we're going to check to see if she's breathing hard. See if you can hear any sounds like stridor. Then right after that, you're going to check your what's called A and P. So you're going to check your posterior and anterior side. So her posterior and her anterior sides, you want to have a 2-to-1 ratio. So take this, measure it here, and you want it to be able to fit twice in her front or anterior side. With hers, it does, so that's a normal finding. So that just, she's not morbidly obese, or we're not worried about any kind of extra problems associated with that. Again, you come back to the chest to make sure it's not concaved or it's not bounding out at you. Then you check the hands to see if there's any clubbing. Clubbing means the bending of the nails at the end of the fingers. You can check cap refills. You see cyanosis or cyanotic. See if they're blue. See if they're any other problems with the hands. You can also check the mouth for cyanosis with the lips, and then I like to check the nares for nasal flaring. And she doesn't have any of that. She's not in any kind of respiratory distress. Her breathing symmetry, it's up and down on both sides correctly. Yeah. And then from there, we're going to go right into palpation. Palpation is when you actually touch the patient, so let them know you're going to touch them. Make sure your hands are warm. The first thing that we're going to do is costochondral tenderness, and that's when you find the intercostal spaces and you kind of find the sternal border, and you kind of just lightly touch in that area and going down. You kind of do it on both sides. Any tenderness there?
No.
Good. You don't want any tenderness, obviously. From here, you want to do tactile phremesis. Tactile phremesis is when you have the patient said 99 and you want to feel the vibration. So go ahead and say 99.
99. 99.
Good.
99. 99. 99. 99. 99.
And you want to do it on the backside too.
99. 99.
Good. And I can feel them in all the fields, so that's a good finding. That's what we want. Next, we're going to do percussion. Percussion is when you take the middle finger and tap it with your other middle finger, and to see if you can hear resonance, which is kind of a clear sound, or dullness. You hear dullness, that's like a mass, or you're hitting bone, or you're hitting something that's in there. So for each one, you kind of tap. You compare it to both sides, so you do side to side. Good. Turn back. Up here. And again, going side to side. And there was nothing that I'm concerned about there. Everything didn't sound dull. It sounded kind of resonance as we wanted. Next thing you do, we're going to do respiratory excursion. And that's when you kind of find this spot here, and you actually have the patient breathe at the bottom of the diaphragm. Go ahead and take a deep breath, and you'll see my thumbs kind of move in and go out with her body. You want to do this technically on both sides. But go ahead, do it again. And you recognize that it's symmetrical. both sides are going up at the same rate, and nowhere is not just one side going up. They're both going together. And that, again, is respiratory excursion. Next, you want to do diaphragmatic excursion, and that's when you have the patient take as deep as a breath as they can, and then you're going to percuss it down, and you're going to find the end of the diaphragm. You're going to do the same thing on the other side, and then you're going to mark it on each side. And then you're going to have the patient take another deep breath, but exhale and hold the exhale, and you're going to mark the bottom of that. And that shows the difference of how far and low the diaphragm raises. You want that between 3 and 5 centimeters. In an athlete, you can have it up to 7 to 8. But if it's not an athlete, you see 7 to 8 centimeters, you should question what's going on there. So go ahead and take a deep breath and hold it. All right, let go. There's that one part we marked there. Same thing on the other side. Go again. And we mark it here. Now let go. So we got our 2 top marks. Now we need to take a deep breath and then exhale. So deep breath and then exhale and hold the exhale. Right, relax. Take another deep breath and exhale out. Good. And if you can see with my 2 fingers, that's the difference right there. And that's about, and it's the difference on both sides. And that's about 4 centimeters right there. And that's exactly what you want to see. From here, we then go to auscultation. Auscultation means listening. So you don't want to hear any stridor or high-pitched noises. You don't want to hear any coarse noises. It's kind of like thin hair. You don't want to hear any crackles or bubbling. Or you want to hear a little bit of swishing in each side, and you don't want to not hear anything. It's called diminished. That's not good either. So we do this in a ladder format, meaning, again, just like we did the percussions, we go to this side, down, and we're going to do that posteriorly, and then we're going to do it anteriorly. When we do it on the anterior, we'll go to the supraclavicle side to start. All right, so go ahead. Every time I touch my sciatic plane, take a deep breath. Go ahead. Good. Good. And always remembering that the right side has 3 lobes and the left side has 2. Can you turn over so everyone can see you? Keep going. And go again. Now, with bigger breasted women, you might want to have them lift up their breast so you can get a good lung sound. I'm okay for right now. All right. Then the last thing we're going to do is we're going to do something called a bronchophony. And that's when you listen to the patient's lung and you want them to say 99. When you listen to it, you want it to be muffled. You don't want it to sound, you don't want to clearly hear the 99 because that means there's something in the lungs, like fluid, that's able to let it resonate to you easily. So again, have the patient say 99 as you're listening. Say 99.
99.
Good.
99. 99. 99. 99. 99.
Good.
99. 99. 99. 99.
And we got to do the same thing on the back.
99. 99. 99. 99. 99.
And I heard them muffled but not clear, which is good, which is exactly what we want. And then that concludes our respiratory video. Thank you for watching.